is the last of a series of talks about fetal monitoring in special circumstances. This is just about medications and what to think about it when we're giving a medication and what to expect to see, etc., and what effect it can have on our monitoring. Okay, I mean, Robin, you're the one who's always being tortured by me, so I'll try and as much as I can to try and deflect the questions towards Tish, but obviously I can't see you guys. But she's also had an extra year of that from me, so all good. Okay. So talking about fetal monitoring in special circumstances, and we're talking about medications. Okay. When we're giving any medications in labor, we need to think about why we're giving it, obviously. Any medications that we administer, we always think about the indication. If we're giving especially for labor or something to do with labor, we need to think about what effect does it have on labor, what am I expecting as an improvement, what am I expecting if things are getting worse, and can this medication add any extra risks to my baby? Okay, it sounds really, really simple and very straightforward. However, that's not always how we think. So let's go through just some of the common examples that we generally use in labor. Yeah. The medication that we use most frequently, uterine stimulants. So obviously oxytocin, prostaglandins, we use them so often, and they do cause quite a bit of damage and harm in the process because we don't necessarily always use them adequately or correctly. Let's start off, what's the indication of usage? So why would I be giving any uterotonics or anything to stimulate contractions?
Induction of labor.
So induction, okay.
Or augmentation.
Augmentation, yeah. So induction is basically starting labor from scratch. We're not contracting as yet, or we were contracting and the contraction has stopped, so we're restarting them again. Or we are contracting and we just don't like how frequently or how strong we are contracting, hence we want more of what we already have. Yeah? Does that make sense? Okay, so, well, that's our indication. Let's think about induction. What risks can a baby face from the induction process?
I guess the risk of hyperstimulation, or tachysystole having an adverse effect on the baby's well-being.
Okay. Anything else?
Risk of uterine rupture if it's a VBAC or not a VBAC.
Okay.
Or
infection if the process is long. It's not related to the drug, it's just the process.
So it's just the process. We're just thinking about the induction itself. So remember, there is an indication to start with. This baby is not coming because it's been completely fine, or it might have been completely fine, but it's now overstaying its welcome. Yeah?
Yeah.
So there is an indication to start with, and that has to make a big difference in what we're thinking when we're actually inducing women. Does that make sense? So
yeah,
a normal, absolutely normal low-risk baby that's coming for post-dates is not the same as a baby that has reduced fetal movements. Okay. We also induce women for preeclampsia, for instance, or prolonged SROM, or meconium-stained liquor. But obviously, as we're inducing, the risk of hyperstimulation is obviously there. So as you correctly said, hyperstimulation is definitely one of the main risks. But so look at the list that we have here. What do you think is the risk being faced by somebody who's coming in because they're post-dates?
Meconium-stained liquor.
Meconium-stained liquor, okay.
I guess there might be a risk of placental insufficiency depending on how far
she is. So obviously 41 plus 6, 42, etc. It can increase. Yeah. Similarly, a baby with reduced fetal movements, is the placenta working okay? Somebody who's being induced for preeclampsia, is their placenta fine? Because remember, you're about to add hypoxia to this baby. So always have chronic hypoxia in the back of your mind. Okay. Prolonged SROM.
Risk of choreo, yeah.
Yeah, infection. And meconium-stained liquor, a bit of choreo. And remember, we want to avoid the white deep decelerations to avoid the gasping for this baby.
Mhm.
Now, what do you think and obviously we're stimulating, so hyperstimulation is the next thing once she actually starts contracting. So subacute hypoxia can start developing in the process, or gradually evolving hypoxia. Yeah.
Mhm.
How do you manage tachysystole if we're inducing somebody with prostaglandins?
Take it out.
Yeah.
Take it out straight away.
Pardon?
Take it out straight away.
Well, I'd probably look at the CTG just because the baby might be coping. The tachysystole might not be necessary.
Okay.
If the CTG is abnormal, then yeah, you can remove prostaglandin.
So if the CTG is normal, will you always leave the propes in?
Assess like resting tone and have a look at the CTG.
Okay. So we have tachysystole but good resting tone. What would you do?
And what's the CTG do?
Normal.
I'd leave it in.
Keep her on the CTG.
Okay. For how long?
Because if you take it out, you're kind of abandoning the process of induction, right? You're
Examine her.
Okay. What if you examined her? What if you examined her an hour ago? Would she have?
Oh, then probably not.
Does it make a difference where within the induction process she is?
It depends how long the process has been. I guess it does, because if it's just been put in.
So.
Well, yeah, what else can you do? Because you're worse off with the prostin. Process best to leave on as long as possible because you know it can come out.
So the idea is that we've all seen once the propes goes in, that first gush of prostaglandins into the lady's system, they start having a bit of tachysystole. Yeah. Just that, and then frequently it does settle. So it basically depends upon what you're going to see on the trace. So if there's no fetal heart rate changes, you can observe. Okay.
Yeah.
But when I'm saying observe, you are gonna need to keep her on the trace as long as the tachysystole remains.
Yeah.
You can't take her off the trace. What you're thinking of is that this may be just that boost of prostaglandins going in. She gets a tachysystole for half an hour, 45 minutes, and then everything settles. Obviously, if it's not settling, then you need to think about it again. If there are heart rate changes, then you need to take the propes out, and you need to tocolyze. Because prostaglandin.
So you wouldn't ever delay that process, would you?
So we're talking about those fetal heart rate changes.
Okay.
So the baby is being affected. Okay, we're not saying about the baby the lady who has tachysystole and not yet, and there's no changes. If she's early phase, there are fetal heart rate changes, then you can observe. You don't even need to take the propes out, okay? Because that's most likely going to settle. But
would you ever be in a middle ground where, like, it's like gradually evolving or anything, where it looks like it's changing? You just want to take the propes out. You don't feel like they need tocolysis. Would that situation occur?
If this is happening within the first hour and the baby is showing gradually evolving hypoxia, what do you think is going to happen to this baby as the labor actually progresses? Only been contracting for an hour and baby's already showing signs of hypoxia. What do you think? Do you think this baby's actually fit for labor?
No.
Okay. Now, the reason I'm saying if you are taking the propes out in early phase, then you definitely need to tocolyze, because that baby we've now just declared that this baby is not fit for labor. And yes, I understand that the manufacturer has said that the propes wears out within 10 minutes, I think, or some even say in seconds. But the reality is that prostaglandin's half-life works for a good 6 hours. So if you are already seeing hypoxic changes, remember this is early on. You've literally just put the propes in, and within the hour she's contracting and the baby's heart rate is showing hypoxia. This baby is most likely not fit for labor.
I've seen someone tocolyze without taking propes out, which I found really bizarre. Is that ever something that you would do? Didn't make any sense to me.
Why would I give both together? A stimulant and a relaxant. Why would I do that?
Well, that's what I thought as well, but I didn't want to mention it.
That is so bizarre.
Susanna, say that again.
That is really bizarre.
Yeah,
Okay.
I agree on that. I don't
Okay,
understand
good.
that.
I was an ST1 and I didn't feel confident enough to question it. But okay, good to know.
Now, if you've taken the Propus out, would you ARM her?
Probably wait a bit just to see what happened.
Okay. Contractions are not settling. Would you ARM her?
And what's the baby doing again?
Baby's now just about settling.
Did we decide the baby wasn't fit for labour or not? We haven't decided that yet.
So this is early on. We've given it within the hour she's hyperstimulating, and we've taken the Propus out and tocolized. And baby's heart rate is now starting to settle. Contractions are just about spacing out. You tell me, what do you think? Do you think this baby's fit for labor?
Baby stimulation doesn't necessarily mean they're not fit for labour, does it?
Sorry, you are breaking away. Say that again. Say that again.
So I mean, quite a lot of babies are going to tolerate stimulation, but they could potentially be fit for labour. So in a more controlled way, if you ARM her and then potentially give her some very gentle Synto, you could see how the baby responds to another form of augmentation.
Okay.
If she's ARMable.
If she's ARMable, you've literally just remember if you've given it within the first hour, she's not likely ARMable yet. You are abandoning the prostaglandin process within the first hour or two. It's different from when you're. That's why I said this is only the early. This is happening in the early phase, it makes a big difference what your baby is responding and how far along is she. Very different from the lady who's had it later on and she's now hyperstimulating and baby is showing signs of hypoxia. Okay, so that baby, you're gonna move and settle this and then try another route or a gentler route than the prostaglandins. Okay, so potentially if we're thinking about a mechanical way or ARMing and trying gentler Synto, okay, but you definitely need to relax this uterus first and let the prostaglandins wear off before you ARM, because if you ARM, you're literally just now counteracting what you've just done. You've taken the Propus out, you've supposedly stopping, you're ARMing, hence you're actually stimulating the uterus again. Does that make sense?
Yeah.
Yeah.
And if you haven't stimulated the uterus, then you've just started the clock on her for no good reason. Like, and you've got to wait for the Tocolytics.
It's not about the clock. If you haven't stimulated the uterus,
okay.
I mean, if you need to get this lady delivered anyway, yes? If you can ARM her, then you're going to ARM her and try with a gentler oxytocin.
Okay.
If prostaglandins, the problem with prostaglandins is they're very more difficult, or a lot more difficult to control. Does that make sense?
Yeah.
Okay. Now, the advantage of
Ahmed,
oxytocin.
can I just make a? Can you hear me?
Yeah, I can.
Yeah. So just to make a kind of a pause and a clarification about this discussion. So we said, and you agreed that if you have a hyperstimulation, you stop it. We did say that makes no sense at all to give terbutaline and not remove the Propus. That is nutters, yeah. We did say that you can remove the Propus and you shouldn't ARM, which was an error of the past, because by ARMing, you are increasing the natural prostaglandins release. So you are giving the baby a rest, and then you can, once the baby improves, you can examine and see where the situation is. If she's ARMable, then you can then ARM and restart the process in a gentler way, knowing that this woman has responded strongly to the prostaglandins. So whatever you do next, you need to be cautious about. Sometimes ARMing is enough to restart the process of contractions. Sometimes you'll need oxytocin, but one way or the other, you need to be aware of the past, of how the woman reacted to prostaglandins, and how the baby reacts to it. I just
Thank-
wanted to, yeah.
Does that make
Thank you.
sense, guys? Oh, thank you, Susanna. That was very helpful.
Yeah, definitely.
Yeah. So what about oxytocin? If you start hyperstimulating with oxytocin, the advantage of oxytocin over prostaglandins is that it's much shorter half-life. So you can start off by actually reducing the symptom, okay? And that generally tends to quieten down the changes. If you're going to tachysystole with oxytocin, you can reduce the symptom rate, okay? Now, even if the baby is not showing any responses as yet, if we keep the lady contracting at 6 and 10, for instance, and we're taking up baby's reserves, we are going to be running into problems. The idea is to make sure that we are taking this slowly to keep this baby happy. So remember, I'm talking about tachysystole. Baby is not responding as yet. Baby is not even feeling them as yet, but I now have 6 and 10 contractions. Does that make sense?
Yeah.
Obviously, if I've reduced the oxytocin, I'm going to observe to see that there's an improvement or not. And if you still have tachysystole, then you stop the infusion. If you're continuing to have tachysystole, and especially if the baby is starting to feel them a bit more, even if you stop the oxytocin, if the uterus is still not stopping the contractions, then you actually need to tocolyze. But it comes a lot later in oxytocin, because oxytocin generally tends to work for a couple of minutes. So hopefully by reducing the oxytocin, you most of the time can actually get away with not having to tocolyze. But it's just about preempting it. So rather getting there before the baby starts becoming unwell, rather than waiting until the baby becomes unwell first, if that makes any sense. Okay, what about augmentation? So why do we augment women in labor? Why do we start oxytocin in labor for augmentation?
Failures progress.
Okay, tell me a bit more about that. So why would she fail to progress?
Because the contractions aren't frequent or strong enough or long enough.
Okay. So remember, we always say about why does the uterus, we don't know why the uterus starts contracting, but we know why the uterus continues to contract. Yes? I mean, Robin, you've always heard me say, you must have heard me saying that a million times before. Babies start, we don't know why they start contracting, but the reason the woman continues to contract is for something called the Ferguson reflex. Okay, so the Ferguson reflex, basically the uterus contracts, it stretches the cervix, and that causes reflex contraction again. And that's what keeps the contractions happening. If the contractions are not stretching the cervix, then the contractions are going to be irregular, or they're not going to be as frequent as we would like them to be, and they will not be progressive, and they will not help the baby deliver. And that's why we fail to progress. So the reality is, if we are thinking about we need augmentation, we need to think about why. Because most common cause is either a malposition or a cephalopelvic disproportion. Okay. The other important cause that we always have to think about is uterine exhaustion. Because the reality is we sometimes bang on so much on that uterus, and she's been in labor for the last 1.5 days, that the uterus is just exhausted. There is no more uterine power. That's why the contractions have stopped. Or she's developing chorioamnionitis. Yeah? Does that make sense? So always make sure that you are assessing why the contractions are stopping. Why are they not progressing? There were contractions to start with. Why do I need augmentation? Before you ever think about giving the oxytocin. Especially in multiples, because multiples generally tend to either deliver quickly or they are really getting stuck. So we are very, very iffy when we're starting oxytocin on multiples. Yes?
Mm-hmm.
Okay. And obviously, if we are stimulating, there's always the risk of hyperstimulation. And the rules are basically, because it's oxytocin, the rules still apply. If the baby is not liking it, or the contractions are too frequent, then you're going to reduce this into infusion. Make sure baby is getting better. If it's not, then you're going to stop the infusion. If it's not getting better, then you tocolyze. But again, don't have, oxytocin generally tends to stop working in a couple of minutes. So tocolysis usually comes a little bit later with oxytocin. Does that make sense?
Yeah.
Okay. What about tocolytics? So we talked about oxytocin, prostaglandins, tocolytics. what tocolytics do we know about, or that we have seen being used, or do we actually use?
Ahmed, can
Yeah.
I just go back on the oxytocin, because there's a couple of messages I want to take the chance to pass.
Yeah, go ahead.
Can I? So about oxytocin, important to say that if you are starting oxytocin on a multip, please, let's say the other way. If you are starting oxytocin on active labor, so you are now past 5 or 6 centimeters, and you are starting oxytocin, can someone tell me a little bit about that? Why would you be starting oxytocin in that circumstance? Have you ever done it? Prescribing oxytocin in active phase of labor?
We're all denying it.
No one has done it?
No, misread. Yeah, misread. Vicky here. Yes, I have done it, and it would be if, well, there was an obvious slowing down of contractions. There was no, like, the power or the frequency tailed off for some reason. But
Okay.
beforehand, I'd want to definitely assess the woman. You know, do a V myself and palpate her abdomen, etc., just to make sure that I think that labour will still continue with efficient contractions.
Okay, so I'm glad that you as a team don't remember many cases where you have done it. I only have one person say, well, yes, I have done it in the past, because I also have done it, but it's a senior and well thought decision, because you know what the evidence is regarding starting oxytocin on active phase of labor. Anyone tells me what is the evidence?
No difference on the outcome.
That?
It makes no difference on the outcome.
Well, if you say outcome as mode of delivery, it doesn't. If anything, I mean, it increases the risk of hyperstimulation. And there's a good chance that increases your risk of going to a section, or by the time you go to a section, you have an impacted head and obstructed, signs of difficult delivery at cesarean section. So the data, and this is Cochrane review, if in the women in spontaneous labor that got to active phase, so they passed 6 centimeters, starting oxytocin or not makes no difference on the way you deliver. Yeah, in terms of, so we're not, if it's with the aim to reduce chance of vaginal or cesarean section, you shouldn't be thinking about that. So starting oxytocin in active labor in women in spontaneous labor will not change mode of delivery. It makes it quicker. So by in an average of 2 hours, but you need to think at what cost. Is it because you then are going to make a cesarean section that is more difficult? Is because you are saving 2 hours in someone that is going to deliver vaginally anyway? Or is because you are increasing the risk of having Tachysystole, Terbutaline, and all the shabam after that? So it's very clear. So anyone prescribing oxytocin in active labor, in someone that got past 6 centimeters on their own, please, you need to think twice. This includes also the second stage. You need to think twice. You need to examine yourself, and you need to probably discuss this with the senior registrar or the consultant. Is this making sense?
Yeah.
Please check the Cochrane review. The data for induction of labor is less strong, but there's a few systematic reviews that if you do sympto for augmentation, so for like Schromm augmentation or induction, again, once they get to the active stage past 6 centimeters, by continuing Synto or reducing or stopping it, it doesn't seem to make a difference in the mode of delivery. This is especially important for multiples. So if you are using oxytocin to induce or to augment in a multip, please bear in mind that most likely you need to stop it or to reduce it once they get to active phase. And what Ahmed was saying about a tired uterus, uterine exhaustion, that's exactly, that's something that, you know, there's more studies coming on, and there's actually now a company that has a device where we can measure lactate in the amniotic fluid to check if, the same way you would measure, you know, if you are running and you have cramps in your legs, probably instead of continue running, you need to give yourself a day of rest. So in labor, you can't really give a day of rest, but you can give a couple of hours of rest. So there's very interesting studies coming on that oxytocin is not the panacea for everything. In many occasions, it gets us and the babies into trouble. I just wanted to share this, and I want to encourage you to read the Cochrane review and some data on oxytocin. Homework. Thank you, Ahmed.
You're welcome. So going back to tocolytics or uterine relaxants, what sort of tocolytics have we, or do we know about, that we can use or we've seen on labor ward? I'm taking away my favorite so that people can't say it.
I don't know any others.
GTN.
GTN. Okay.
We don't really know evidence for it. What? Nifedipine. Yeah, nifedipine.
Nifedipine. Okay. Anything else?
Pain relief.
Say that again.
I mean, it's a bit of a punt. Pain relief.
Pain relief. No, so that's not a tocolytic. What sort of pain relief are we talking about?
Epidural that often, I mean, I don't know the mechanism, but you've seen the contractions occasionally go with adequate pain relief.
Yeah, I'm gonna go back to why in a moment.
Okay.
So why contractions settle with epidurals? I'll explain why. But anything else that you've seen on labor ward that can potentially cause relaxation of the uterus?
A GA.
A GA? Well, no, we don't use that, but magnesium sulfate is
I
actually
know. I know.
We're running out.
We're desperate.
and non-steroidals.
Okay.
Okay. Let's talk about how each one of them works. Do we know how terbutaline works as a uterine relaxant?
No, it's a beta-2 agonist.
It's a beta-2 agonist, so it stimulates the beta-2 receptors of the sympathetic. Yeah, and similarly, salbutamol, and before both of these, there was something called ritodrine. Yeah. Okay. What about GTN? Do we know how it works as a tocolytic?
Yeah, vasodilation somehow relaxes the uterus.
So it's a small muscle relaxant. It's not about the vasodilation, but it's in a similar fashion. It's a smooth muscle relaxant. Yeah. Okay. Nifedipine.
Something to do with calcium channel blocking.
It's a calcium channel blocker. So it basically, again, it relaxes the smooth muscles by blocking the calcium channels. And in the similar way, magnesium sulfate works because it's another anti-calcium. Now, non-steroidals is actually, it used to be a well-known tocolytic that we used to use for long-term. Many people would have heard about something called indomethacin. Okay, very, very old days. The idea is that if anybody is on non-steroidals, which they shouldn't be in labor or in pregnancy anyway, it can be a tocolytic, but it's just mentioned here just for the thought about it. Okay, so I was saying that non-steroidals, you know, many of you might have heard of me that we can sometimes use Voltarol as a very last resort with pyrexia, but the whole point is that it can also mess with our contractions. but we don't use it as a tocolytic, and we don't generally tend to use magnesium sulfate as a tocolytic either. But it's just an important thing to think about when you're having to give something to relax. Yeah. Okay, let's go with the one that we actually use a bit more frequently. Let's go with terbutaline. So why are we giving terbutaline?
Because of hyperstimulation.
Because we're hyperstimulating. Okay, when would we give it?
When
After stopping the Synto, or
After stopping the Synto, yes. So after taking the ProPES out as well. Just as a by the by, Robin.
yeah, no, it wasn't my idea. It wasn't my
I know
idea.
it wasn't. I'm just pulling your leg.
the clinically worsening trace
So
by time before, if it's a clinically worsening trace and you've already used conservative measures like stopping the Synto, I mean, would you want to give it prior to the deteriorating trace?
So the idea is you're trying to improve the baby's conditions, because we think that the baby's conditions are being worse because of a stimulant or because of uterine contractions. Okay. Now, if the uterine stimulation is happening because we're giving a medication like prostaglandins or like oxytocin, then yeah, then terbutaline would be indicated there. But if uterine contractions are happening because the uterus is being irritated by something else, like abruption or a placental bleed, then we should never be using terbutaline there. That's why it's important of what's the clinical picture of the indication. Does that make sense?
Yeah.
Yeah.
So somebody in labor who's now contracting 6 and 10 spontaneously, or because of the oxytocin, or because she had prostaglandins and she's hyperstimulating on that, yes, that's indicated for terbutaline. But somebody who is coming in, she's 30 weeks and she's contracting, okay, well, there's probably something else happening behind. There may be an infection there. There may be a bit of an abruption there, especially if she has a bit of an irritable uterus. Then I should be thinking more than twice before actually giving terbutaline. Because if I do have an abruption there, terbutaline is actually going to make it worse, and it's not going to resuscitate the baby, but actually can separate the placenta completely. Does that make sense?
Yeah.
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 If you're giving it with oxytocin, as long as the baby, I mean, it depends upon how unwell or unhappy the baby is. Remember, we said when we're giving oxytocin, we can preempt things. We can try and reduce the contractions, even though the baby's not unhappy yet, to make sure that the baby does not become unhappy. So if we're not catching up because baby is really unwell right now, we can just try stopping the stimulant first, seeing whether baby's improving or not, and then giving terbutaline a little bit later. While if we're giving something that's going to be longer acting, like I can see a baby's really unhappy with prostaglandins, then just taking the ProPES out is not going to improve the baby. Actually, I have to tocolyze. So I need to make sure that I understand what is the clinical picture of my indication. Yeah. Now, the intended benefit is that the uterine contractions are going to settle to try and improve the baby's condition. So the first response I'm going to see is that, or at the same.
I'm gonna put it in even more blunt.
Yeah,
So,
go ahead.
Can I?
Yeah, go ahead.
So it sticks into everyone's minds. In the antenatal period, unless you have used, so in the process or infection or blood.
Abruption.
So it's the two things that you need to think about. It's not about terbutaline. So I want terbutaline those pictures is because in our minds, if you use terbutaline, you have the false impression that you are improving things, where actually you are either doing nothing or deteriorating, but especially because it stops you thinking why, it will be a delay. And if it's an abruption, it could be a delay. It is making sense.
Yeah.
So someone coming in the antenatal period, lots of contractions, distressed or not, the CTG with this uterine irritability, the two things to think about is about infection and blood. Remember that a simple UTI can cause lots of uterine irritability. Usually the babies are completely well. Yeah, you have a normal CTG, but a mum in pain and lots of contractions. And abruption, you can have abruption without external bleeding. How do you call that?
Concealed abruption.
Concealed abruption, yeah. And an abruption before you have, a picture with, what comes in the books, bleeding and hard rock uterus, you may have this, the evolving picture of someone coming, reduced fetal movements and abdominal pain, and not always you have the bleeding. And especially if the placenta is posterior, sometimes the uterus may not feel very hard, rock hard as it comes in the books. Have anyone been in that situation?
Not me.
Okay, so we have at Kingston, and I don't want you to be on it again, either at Kingston or when you move on in your career. So please keep this in your mind. Uterine irritability, not in labor. Think infection or blood, never terbutaline. Ahmed, I think you are back. Are you back?
Yeah, I am. Yeah.
Oh, good. I was just making time for you. Go
Thank
on.
you. Okay, so did you guys understand this about thinking about the clinical picture that you were already seeing while you're tocalizing? Yeah.
Yeah.
Now, this is something that we always talk about when we're giving terbutaline. We generally tend to give it with a baby that is showing it's becoming unwell, and it's usually that this baby is going through gradually evolving hypoxia. So the picture that we're looking at is usually that the baby's baseline has gone up because baby has started secreting adrenaline. So baby's basically started compensating, which is going to take baby's heart rate up. Okay. Now, as long as the adrenaline is still running, the baby's heart rate is going to continue to be fast. We're good doctors, or we're good clinicians. We've recognized that. We've stopped the stress. We've given terbutaline. Now, what is terbutaline? A beta-2 stimulant. Yeah. So does that have any effect on baby's heart?
Causes fetal tachycardia.
It can cause fetal tachycardia. So baby's heart rate is supposed to go up. Yes. But as we've given the terbutaline, the adrenaline is supposed to get better because now the contractions are settling. So the heart rate with the terbutaline going away is supposed to come back down. But the terbutaline is pushing the baby's heart up. So basically what should happen is that they should cancel each other out, and baby's heart rate should stay the same. But if baby's heart rate is staying the same, how am I supposed to know that baby's getting better? Say that again.
If the adrenaline is going down, would they maybe have some more accelerations?
So baby might start accelerating even before that.
And stop decelerating.
Not completely, unless you've completely taken all contractions away.
It'll cycle again.
So first sign of improvement is that the contractions start spacing out. Yeah, that's your first sign of improvement. Now, if you have been monitoring her properly and you actually have noticed that the mum has a pulse oximeter on, you would notice that mum's heart rate has gone up after your terbutaline. That basically tells you that terbutaline is now working. Okay, so first sign, her heart rate goes up and contractions space out. That means that you have a maternal response to terbutaline first. Second sign, if the terbutaline is now working and the adrenaline is supposedly going away, the fact that the heart rate stays the same, that basically tells you that the terbutaline is also working, because now the baby has become tachycardic even though the adrenaline is now going away. So the fact that it stays the same, that's your second sign that terbutaline is working and the baby is getting better. Does that make sense? Guys, am I still making sense?
Yeah. Is this mute?
Okay. But how long is the baby gonna stay tachycardic for? As long as the terbutaline is still running into the system. Okay. And terbutaline usually works for a good 2 hours. So after the terbutaline is worn off, that's only when the baby's heart rate is going to settle back down. Now, what you don't want to see after you've given terbutaline, one, the baby's heart rate going up. So if the baby is now becoming even more tachycardic, that means that you've either made this baby worse by stimulating it, putting more pressure on its heart, even though it wasn't already happy. Okay. Or this baby was never hypoxic to start with, so there was never adrenaline to start with, and that rise in baseline is actually because this baby's tachycardic for something else, most likely for pneumonitis.
So
Does that make sense?
How are you going to distinguish those two time frames?
Say that again.
So a trace that's continuing to go up, you're not going to see it as a beautiful step. You're going to just see it as a continuation of a rise that you're not going to know whether it's due to. You're going to see the initial like rise from the adrenaline, but we don't. If you're giving terbutaline relatively early, you're not going to know whether or not that's a continued rise from the adrenaline or the effect of the terbutaline.
So the idea is that if it stays the same, that means that's the. I mean, are you saying that you've given terbutaline here?
Maybe a bit further along.
So if you're giving it here, adrenaline is already working. And if you give terbutaline and adrenaline and terbutaline are working together, you will have a further rise. So your signs of improvement. One, the mom is going to become tachycardic. Remember, the mom had no reason to become tachycardic to start with. Because even though the baby was hypoxic, the mom was never hypoxic. So mom's heart rate should have stayed the same. If you have a pulse oximeter on mom, a couple of minutes after you've actually given terbutaline, you'll notice that her heart rate has gone up. That's a sign that terbutaline is now in her system and is actually circulating and working. You would notice that the contractions are spacing out. So that's again a sign that terbutaline is now effectively working. If the baseline stays the same, that means that the terbutaline that's now working has improved the adrenaline, which means that the adrenaline is improving. That's a sign of improvement. The fact that the baseline stays the same, that's a sign of improvement. Okay. If there were no improvement, the baseline will actually go up further because now you have adrenaline and terbutaline working together. So if you have noticed that the baseline went up further when you're given terbutaline, okay, you need to go back and revise. Either indication to start with was wrong or baby's not improving. Does that make sense?
Yeah.
And as I said, once the terbutaline wears off, and that usually takes about 2 hours, then the baseline will come back to where it was supposed to be.
That's just a long 2 hours of faith that it's not going to go up.
No,
I mean,
you are going to be observing anyway.
Yeah.
But you then, if you get to adrenaline again, you will have another rise in baseline. So you'll have a further rise in baseline. So if by this point adrenaline is being released again, you'll notice that the baseline is now going up once again. If the terbutaline is wearing off and adrenaline is coming back, you'll notice that it's now going to persist and now it's going beyond the 2 hours. Remember, you're always looking for the rest of the signs. It's not just about what the baseline is. The next step is what is the variability doing? Is the baby still cycling?
Yeah.
Are the decelerations still wide and deep? Does that make sense?
Yeah.
So it's not just about the trace, it's always about the entire clinical picture. That's always what we're looking at. Okay. So what about GTN? Why do we not use it more often? It has no effect on the heart rate, does it?
Does it cause maternal hypotension?
It causes maternal hypotension. And that's a very, very important point. Remember, if this baby is already hypoxic, I don't want to be adding to this baby's hypoxia. Okay, so I don't want to make her hypotensive on top of the baby becoming hypoxic. Now, when would I use GTN?
Would you use it during a section as a uterotonic to help disengage a
Tocolytic, you mean, not a uterotonic?
Yeah, that's the one.
Yeah, that's the one. So you use it during a section. Why do we like using it during a section rather than terbutaline? We just said it causes hypotension. You've just topped up her spinal and you're giving her GTN that causes even further hypotension. Why would I prefer GTN to terbutaline then?
Vasopressors when they have hypertension. I don't know.
Because it's much shorter acting. That's why people like it a bit more. Okay, it doesn't act for as long, for the same length of time. Okay. However, I personally actually prefer terbutaline in sections rather than GTN. But that's just a personal preference.
What was that? We missed the actual reason, sorry.
So the reason why people don't like, or they like using GTN in preference to terbutaline in sections is because GTN is shorter acting. Which also means that if you're using it as a tocolytic while she's still in labor, you're more likely to have repeated doses of GTN. Okay, because it's gonna you're gonna give it 5 minutes and it wears off. You have to give it again 5 minutes and it wears off. Yeah. In cesarean section, I actually generally prefer terbutaline because she's already has a spinal, hence she already has a potentially hypotension. I don't want to be adding to that. That's why I generally tend to use terbutaline, and I can always give things to make the uterus contract. So, does that make sense?
Yeah.
Okay. We're coming very close to the time of our. Well, I know that you guys have to go, but we're just gonna run through this. This one's quite an important one. So antihypertensives. Okay. So first line treatment on our NICE guidelines is labetalol. Is that correct?
Yeah.
Okay. So do we know what labetalol is?
Beta blocker.
It's not a beta blocker. Let me rephrase that. It's not just a beta blocker. It's an alpha and beta blocker. Okay. And the reason this is very important is because I need to think about what effect it's going to have and what risk can it actually present on baby. So labetalol, as I said, is an alpha and beta blocker. It blocks the entire sympathetic system. Okay, why do I give it? I give it to women who are hypertensive. How does it help their hypertension? So the sympathetic works with two systems, two receptors, the alpha and beta. The alpha receptors are the ones that facilitate the vasoconstriction, so the redistribution from other organs. The systemic pressure or arterial tension is alpha receptor mediated. So if you relax the alpha receptors, you're basically causing vasodilatation to the periphery, hence reducing the diastolic pressure, and in general, the blood pressure in general. Okay? The alpha receptor is also what causes, or a bit of beta 1 and alpha is also what causes the uterus to contract, the heart to contract stronger. Okay? So also you're reducing the contractility of the heart when you're giving labetalol. The beta receptors are one who facilitates the tachycardia. So you're actually slowing down the heart rate, hence reducing the cardiac output by 2 means. Okay, does that make sense? That's how it actually works. Now, labetalol crosses to the baby. Let's imagine what effect that can have on baby's CTG or on baby's heart rate in general. Where do you think the baseline is going to, what's going to happen to the baseline?
Go down.
So it's going to drop a bit because we have less sympathetic or almost no sympathetic. What about variability?
Juices.
It's going to reduce because variability is the interaction between sympathetic and parasympathetic. If we have no sympathetic, there's no interaction. So it's just a variation within the parasympathetic. So yes, reduced. Okay, which means that cycling can be a bit tricky to figure out. Does that make sense?
Yeah.
Okay, what about accelerations?
Shouldn't affect.
Shouldn't affect them because accelerations are a somatic system, and this is not blocking the somatic system, and it's not making the baby sleepy or the mom sleepy. So acceleration should still be there. What about decelerations?
They'll still be there as well, right?
They should still be there because decelerations are parasympathetic and we're not blocking the parasympathetic. So we're going to end up with a baby that has a lower baseline, reduced variability. Okay, you can wake it up, you can stimulate it, so it can accelerate if you stimulate it, and it can decelerate if there are cord compressions or if there is any hypoxic events. Okay, now the problem with this baby is that as the hypoxia becomes worse or progresses, what's supposed to happen to this baby's trace? So we're going to start off with a normal trace and then start some cord compression, so some decelerations on the trace. And as it's getting worse and worse, the next step is because the baseline should be going up. Is that correct?
Yeah.
That's the sign of compensation. That's for adrenaline release. Now, is this baby's baseline going to go up?
No, not as much. It's like trying to go for a jog on a beta blocker.
Precisely. So it can't raise its heart rate. Can it actually redistribute?
Yeah. So,
Remember, redistribution happens by alpha receptors. Labetalol is an alpha and beta blocker. So actually, no. So this baby's one of the very important protective mechanisms, which is centralization, this baby has blocked. And it also doesn't have the ability to tell you so. Okay. Now, you have recognized that this baby is becoming unhappy or unwell, and you want to make this baby happier, and you can see that the contractions are becoming a bit too frequent. What are you going to do? We've stopped the synto. She's still contracting too frequently. What can I do? Tocolyze? Are you guys still there?
we're just in thought.
You're just in thought. Okay. So if the baby's becoming unhappy, I might need to tocolyze. Is that correct?
Yeah.
Yeah.
Can I tocolyze using terbutaline?
Yeah, but then that might increase the mom's blood pressure.
Okay. What did we say terbutaline was again?
Mix.
It's a beta stimulant. What's labetalol again?
It's blocked.
An alpha and beta blocker. So terbutaline, you give terbutaline, it's not going to work because you have the receptors blocked. Remember that. So labetalol is supposedly blocking the sympathetic system in mom and indirectly baby. But you want terbutaline to work on mom's sympathetic system, but she has a blocker in place. So no, it actually can't work. You need to think about something else to tocolyze if you really want to tocolyze, which is why you need to actually be very much in control when somebody's on labetalol and on your ward.
But won't it depend upon when the patient had the labetalol dose?
Sorry,
To
say
the
that again. I
half-life?
couldn't hear that. The voice was breaking. Say that again.
So won't it depend upon when the patient had the labetalol and depending upon the half-life? If it's been like, if she's on a BD dose and it's been like 8-9 hours since the last dose, or 6-7 hours, wouldn't there still be some receptors which will be still be able to
So
work?
obviously it is dose dependent. That is absolutely right. So it is obviously dose dependent and it depends upon when she's had it last. Okay, but just be aware that you might be giving, if you're giving terbutaline, it might not work because she is blocked. And labetalol, the tablets that we give, are generally tend to be long acting. So it works for a good 8 to 12 hours. We give labetalol twice a day, don't we?
Yeah.
So that means that it's working for a good 12 hours for you. And by the end of the 12 hours, you're giving her the next dose. Now, the other thing is, remember by the end of the 12 hours, you're facing another problem. Because as the labetalol is wearing off and as she's coming up to her next dose, what do you think is going to happen to baby's heart rate? It's going to start rise. And the first thing we're going to think of now, is this rise because of the labetalol wearing off, or is this because baby's becoming unhappy? We really have no idea what's going on. It can be quite tricky to manage. So you have, again, to look at the entire clinical picture once again to make sure that you're not missing a hypoxia that's developing and not confusing it with just the labetalol wearing off. Does that make any sense?
Yeah.
Okay. And remember, if the lady has higher dose of labetalol, this baby has reduced compensatory mechanisms because it can't centralize its oxygenation. So just keep that very much in mind. Okay. Obviously, we can't badmouth labetalol without just mentioning nifedipine. Obviously, it's the best thing that's happened after sliced bread, isn't it? However, having said that, nifedipine works by causing smooth muscle dilatation. In itself, it relaxes the uterus and it can make the contractions irregular. It can also make the lady hypotensive, so it can add potentially to the woman's or the baby's hypoxia. So again, women with hypertension need particular attention in labor, because on top of all of that, remember, they are the ones that actually come with the chronic hypoxia babies. Are you guys still there? Sorry, Zoom keeps on breaking, so I'm not entirely sure what's happening. Can you still hear me?
Yeah, we're still here, just terrified of all the women on antihypertensives now.
It's not about being terrified. It's
I'm joking.
making sure that you know what you're doing, and hopefully that gets you safely across and babies safely across. Okay, I was supposed to be presenting a case, but I think we've run out of time. Do you guys have any questions?